Welcome to AETCM, the emergency medicine channel. So, we started the neurological emergency. So, in this part, we are going to discuss the cerebrovascular accident. So, our content is a definition, what are the types is there, and then pathophysiology, assessment, and then finally management portion. So, what is mean by brain attack or stroke or cerebrovascular accident? So, both terms are indicating the same thing only. So, what is mean that? So, blood supply to the area of the brain is interrupted or reduced is called the stroke or CVA or the brain attack. So, the main goal of the treatment here is we have to recognize that is a stroke, and then rapid and then appropriate intervention should be taken. That is the main goal of the treatment in the stroke. So, this here we are calling as a time is brain. So overall, if you are looking this context, the major things. So blood supply to the area, or you can think about the ischemia, and then time is brain. So you will divert your thing into the ACS. So that the same thing only will occur in the acute coronary syndrome, right? So in acute coronary syndrome, what will happen? The blood supply to the myocardium will reduce. What is happening in stroke? Blood supply to the area of the some portion of the brain is reduced. In acute coronary syndrome, what we'll call time is muscle. In your stroke, what we are calling time is brain. So this is the somewhat difference. The context is same, but the area is different. That is one of the thing. So, and one form of stroke is a mini stroke or transient ischemic attack. What is mean by transient? Transient means temporary. So, it is a temporary episode of cerebral ischemia without any permanent damage. So, here whatever symptoms, clinical symptoms that occurring in stroke, the same thing that will depict in your TIA or transient ischemic attack. There won't be any changes. So, whatever though we will see the facial drop, arm drifting. So, everything that will occur in the TIA also. But the major important thing that will resolve within 1 hour based on American Heart Association what they are telling. So, within 1 hour the symptoms will be resolved. So, that is called the mini stroke or TIA. So, what are the major basic two types only we have? First one ischemia and then hemorrhagic. So, ischemic in the sense because of the occlusion. So, hemorrhagic in the sense that is the bleeding, right? So, ischemia occurs because of the thrombus or embolism. So we know embolism means that might be a amniotic fluid embolism or air embolism or catheter embolism or thromboembolism. Thrombus means there is a blood clot. So whatever thing. So hemorrhagic in the sense aneurysm, hypertensive cerebral hemorrhage or subarachnoid hemorrhage, epidural hemorrhage, whichever thing. So that is a hemorrhagic related one. So ischemic one is 87%, hemorrhagic one is 13% of incidence. So pathophysiology, ischemic wise, so we told, so there will be a problem in the your blood vessel. Means if you remember the perfusion triad in cardiovascular emergency one day we discussed, if we want a effective circulation or perfusion means three major things is important. First one is your container, second one is your content, third one is a pump action, right? Container means blood vessel, content means blood, pump means your cardiac activity. Here no problem in your pump, so cardiac activity is good, your content also is there, adequate blood volume will be there. Content, there will be a problem in your content in the sense your blood vessel. So here we told there is a occlusion because of your catheter or thrombus or embolism, whichever thing. So think here it is a form of atherosclerosis, or there will be a form of some set of occlusion. So distal to the occlusion there will be ischemia will occur. That is why we are calling the self-limiting or self-limiting in the sense, so it won't affect the whole portion. For example, take your cerebral circulation, we can take the pontine artery, so which is supplying to your pons, right? So if any problem or any occlusion in the pontine artery means it will affect only the pons. So that is called self-limiting one. Again, distal to the area will become the ischemic. Distal to the occlusion there will become a ischemic. There is a two major pathophysiology that will occur in the ischemic stroke. So here you can see the That yellow line is depicting the signs and symptom of ischemic stroke. So here you can see the time, here you can see the signs and symptoms, right? Clinical presentation. So when the time increase, signs and symptom also get worsened. So for example, you can take, this is the 1 hour, this is the 2nd hour, this is the 3rd hour, 4th hour, 5th hour, 6th hour, like that. For example, we are taking, it will not occur at a time basis. So it may occur in a seconds or minute basis also. For example, I am telling 1 hour, 2 or 3 hours. So you can see in first hour there is a elevation in the, there is a worsen in the signs and symptoms. So in 2 hour again worsening, 3rd hour also worsening, 4th hour, from 4th hour it is become a steep first or plateau line. So what is indicating the plateau line? So in the first 3 hours, the blood supply to the specific area get reducing. For that, some set of damage will occur. So again, if you are not treating, means from 4th hour itself, there is a complete occlusion or there is a complete interruption of the blood supply, that is causing the permanent damage in the whole area. That is why it is causing the, it is maintaining the plateau level, right? So it is calling the ischemic stroke. Then coming into hemorrhagic stroke, hemorrhage means simple, it is a bleeding. So whenever the bleeding, so here also the same thing, the red line depicting the your hemorrhagic stroke signs and symptoms. So as the time increase, the amount of bleeded blood level will increase inside the cranium. Clear? So hemorrhage means bleeding. Sorry. Hemorrhage means bleeding. So when the time increase, the amount of blood collected inside the cranium will increase. That will cause two major things. First one, it will increase the intracranial pressure. Second one, it will cause the brainstem herniation. So hernia means we know that is an abnormal protrusion of organ or something. So here, because of the increased amount of blood inside the cranium, that will shift your brain into the outer portion, means through the foramen magnum your brainstem will herniate. That is the two major thing, increased ICP and then that will herniate your brainstem. So here the signs and symptom wise, the person they will complain the worst headache of my life, and then it will progress. First it will start with the headache and then can't unable to speak, and then they will show the signs of increased intracranial pressure. So as we talking regarding intracranial pressure, it is most important to learn about the Monroe-Kelly doctrine or hypothesis. So what the thesis is describing means, so think our cranium contains the three major structures: brain, blood and then CSF, cerebrospinal fluid. Brain, blood in the sense cerebral blood flow, and then CSF, we know CSF. So here, if any problem in the one among these three, means the remaining two has to be accommodate the space. For example, so it is a easy concept. So just think, you have a 3 chairs for 3 persons. So the rule is everyone need to be sit on the chair. So that is the rule. Okay. So 3 person, 3 chairs means there is no problem. Each person will take the one chair. So the same set of scenario, 2 chairs for 3 persons means what we'll do. So one person will accompany one chair and then remaining 2 person will accompany the another chair. So that is the sort of mechanism we'll do. No, the same thing only. If any problem in the brain, means the cerebral blood flow and then your CSF need to be accommodate the space. So why means your cranium is a rigid skull structure. So it is a rigid bony structure. We can't expand the structure based on the amount. We can't expand the structure. That is why if any problem in the one among these three, means the remaining two has to be accommodate the space. So here the brain is least compensatable one, means it can't accommodate its space. Blood is he is a selfless guy, so he is a highly auto-regulated one. So whenever problem that happen, the blood flow only alter its space. So normal cerebral perfusion pressure is 60 to 160 millimeters in mercury. So if the perfusion pressure goes less than 60, means that will affect your cerebral blood flow. So the calculation wise, you can calculate MAP minus intracranial pressure. So what are the assessment point? We'll see language effects, slurred speech will be the aphasia and then agnosia and then apraxia. So these three things are cognitive related. Aphasia means, so the person inability to identify or understand the language or speaking inability, that is the aphasia. Agnosia means unable to remember the familiar object or person or taste or something. Okay, so apraxia means unable to use the familiar equipments, means they are they are failed to recognize the object, right? So for that reason they don't know how to use the object properly. That is the apraxia. Aphasia, agnosia, and then apraxia. Movement effect, hemiparesis, hemiplegia, arm drifting, facial rub, tongue deviation, swallowing difficulties, ptosis will be there, ataxia. Sensory effect is headache, in hemorrhagic, worst headache will be there, sudden blindness, sudden unilateral paresthesia will occur. Cognitive effect will decreased LOC, difficult thinking, seizure, coma. Cardiac effect, hypertension will occur. Increased ICP, because increased ICP, bradycardia, irregular breathing pattern, hypertension, and then this is a normal assessment, right? Be fast in the stroke. So balance will be ataxial related will be there. For eyes, ptosis will be there. Facial symmetry of the face will loss. Arm drift will be there. Slurred speech will be there. Time. This is the time to act. So increased ICP signs. So in the case of hemorrhagic strokes, so these are the signs will occur: bradycardia, bradypnea or irregular breathing pattern, widened pulse pressure. So pulse pressure means that is the difference between the systolic and diastolic. So we should not tell blindly hypertension. This word is most important: widened pulse pressure. These are the three major signs that will occur in the increased intracranial pressure, that is called the Cushing reflex, right? So widened pulse pressure, systolic hypertension will occur. So other signs, decorticate poisoning. So yesterday we discussed decorticate means abnormal flexion, decerebrate means abnormal extension, anisocoria, dilated pupil, unresponsive pupil, biot respiration, apneistic, sign stroke respiration, that will occur because of the increased intracranial pressure. So management wise, the same thing, we have to see inside the form a generalized impression, the mental status we have to assess, life threats. What we are focusing on pre-hospital means yearly we have to recognize and then we have to manage the life threats. If anything regarding we told in increased ICP, bradycardia and then bradypnea will occur, no? That we have to manage in the pre-hospital scenario. So if time permits, we can quickly review the fibrinolytic checklist. So fibrinolysis mainly will do in the case of ischemic. So again, without imaging, we can't. It is difficult to identify which is which is ischemic, which is hemorrhagic stroke. Anyway, if we are seeing the signs and symptoms regarding increased intracranial pressure means, then we can suspect that is a hemorrhagic strokes. Again, if time permits, we can do the fibrinolytic checklist. Based on our protocol, we can go through, and then we have to transport the person nearer the hospital as early as possible. So in the case of increased intracranial pressure, so if you are witnessing any Cushing reflex or decorticate, decerebrate, those are things if you are witnessing means that might be a hemorrhagic stroke. So you can do the two major things in a pre-hospital. First one, head up, head and elevation. Second one, hyperventilation. Two simple steps. So first one, head up position. So whichever emergency, first our thing is positioning, right? So head up position means here just elevate the head end of the person 30 to 45 degree. That is enough. And then before doing it, just to verify whether the person have a cervical spine injury. That is the first step. Second step, hyperventilation. Hyperventilation means we are ventilating the person beyond the normal. That is the hyperventilation, right? So based on brain trauma foundation, they are recommending 20 breaths per minute in the adult, 25 breaths per minute in child, 30 breaths per minute in the infant cases. So these are the ratio. So we have to, if we have a ETCO monitor, we can maintain the ETCO to 30 to 35 millimeters in mercury. If ETCO2 goes less than 30 means we should not initiate the hyperventilation. Why we are focusing on ETCO2 means in hyperventilation what will occur, there will be a elimination of carbon dioxide. So it leads to the hypocapnia, right? So for that reason, if the ETCO2 level is less than 30 means we should not initiate the hyperventilation, keep in mind. And then so what's the mechanism behind the hyperventilation? So the same thing only, the hypocapnia will occur. Hypocapnia will constrict your vasculars, thereby blood supply to your brain will reduce, thereby the perfusion reduce means, so the pressure inside the cranium will reduce because of the perfusion pressure reduced. So again, hyperventilation is a temporary measure. We can manage some set of time in the pre-hospital scenarios. So head up position, second one hyperventilation. If it is a in hospital means two more steps will follow. First one is your corticosteroids, dexamethasone, hydrocortisone, that will give. Third one is fourth one is your diuretics or 3% saline or mannitol. So what is the role of mannitol and 3% saline? So it is a hyperosmotic fluid, right? So it will act as a osmotic diuretic. So it will suck out all extra fluid or edematous fluid from your cranium, and then thereby it will reduce the volume of your cranium. So that is also we can follow, but it is mainly following in the will follow in the definitive care only. So in pre-hospital head up position, hyperventilation is more than enough. So management again, if we should maintain the patent airway. If anything secretion we are finding means that we should not be vigorously suction, that will stimulate the cough and then gag reflex. Again it will leads to the increased intracranial pressure. We have to watch for any seizure. If seizure activity is there means we can administer benzodiazepines, and then we have to watch for the again in the case of increased intracranial pressure, we told bradycardia will occur. Normally, if the bradycardia occurring means what we'll do the injection atropine IV will give 1 mg, max of 3 mg. Again, if it is not responding means then we'll go with a transcutaneous pacing, dopamine, epinephrine infusion. Those other things will follow, right? That should not be done in the case of this increased ICP cases, right? Because the problem is in the brainstem herniation. Because of the pressure only it is occurring. So not because of the other reason. For that reason we should not do. Again, the second major important thing here, the systolic hypertension is there for that reason. So again we have to notify the hospital, provide the prompt transport, and then we have to, there is no such recommendation by the AHA to for pre-hospital control of hypertension, and then don't administer aspirin. So if you are thinking about ACS, there will administer aspirin in the pre-hospital, right? Non-entry coated aspirin will administer. But in the case of stroke, there is no such recommendation we have. So this is the some pre-hospital fibrinolytic checklist. So here you can see the time signs and symptoms begin, or if when the person appears as a normal. So and then blood glucose level and then blood pressure we have to record, any facial drop, slurred speech, arm drift is there or not, and that fast assessment, right? And then time related. So in past 7 days the person when gone through any procedure which they are pricked any arterial puncture. In 14 days they were gone through any major surgery or trauma related. In past 21 days any patient had any history of bleeding related thing. In past 3 months, has the patient experienced any MI, myocardial infarction or stroke or head trauma? In bleeding related, or the person have a current bleeding or clotting problem, and then the person have a signs and symptom of stroke rapidly improving. Does the patient have a increased intracranial bleeding either now or in the past? These are the bleeding related history, or if the person taking any anticoagulant medication. So these are the things we have to take it out in the pre-hospital if time permits. So critical time period for the administration of fibrinolytic therapy. So this is mainly for this is a protocol for the inside the ED or definitive care ED for emergency department, not for the pre-hospital. So once the person reach out the ED, within 10 minutes we have to do the general assessment. Within 25 minutes we have to acquire a CT and the neurological assessment we have to do. Within 40 minutes we have to interrupt the CT, whether that is a ischemic stroke or hemorrhagic stroke. Within 60 minutes we have to puncture the vein, and then we have to administer the fibrinolytic therapy. That is a door to needle time. Right? And then within 3 to 4.5 hours we have to administer the fibrinolytic therapy timed from onset of symptom. So don't confuse with this one to this one. So here door to needle time means from the person arrival to the ED to the therapy. For that time is a 60 minutes. From timed from the onset of symptom is a 3 to 4.5 hours, or mean you can take as a 4 hours. So administration of endovascular therapy, if the person is not a candidate for fibrinolytic therapy, contraindicated means, then we'll go with the surgical intervention that should be done within 6 hours, and then within 3 hours we have to admit the patient in the stroke unit. So again, this is also for in-hospital management for the acute coronary, sorry, your stroke. This is given by the American Heart Association. So here you can see this the same thing only. In pre-hospital, what we are doing, we have to support the ABC. If time permits, we can do the fibrinolytic checklist and then alert the hospital, glucose level we can check. So once the person reaches inside the ED, these are the immediate general assessment within 10 minutes we have to do. So again reassess the ABC and then we have to stabilize those parts, administer oxygen, IV access, glucose level and then neurological screening, 12 lead ECG and then CT scan, MRI, activate stroke team. So within 25 minutes, we have to review the present, past medical history, surgical history, hemorrhage, lot of things we told, right? That we have to rule out, and then we have to, within 45 minutes, we have to interpret the CT, whether that is a ischemic stroke or hemorrhagic stroke. If it is a ischemic stroke means, then we have to think about the fibrinolytic therapy. So whether the person is indicated for fibrinolytic therapy or contraindicated. If the person is a candidate for fibrinolytic, other the person, if the person is indicated for fibrinolytic therapy means, then you can go with a recombinant tissue plasminogen activator, that is your altiplase, right? So that we can administer, and then no anticoagulants or antiplatelets treatment for the first 24 hours. So anticoagulants means heparin, warfarin, antiplatelets means your aspirin, ecospirin. So that should not be, that should should not be for the next 24 hours, or that should withhold for sometimes. That should be done within 60 minutes. So after so within 3 hours we have to administer the person under the stroke unit, intensive care unit. There we can take out the BP control, everything we can do. So in, if it is a hemorrhagic stroke means, straight away we can take for the person to the procedure. So this is the whole thing regarding the CVA. Do your best. Shalom.